today. Hello? There we go. We're appreciative of all of you being here today. I know that there would like to be questions that each of you would ask, but instead what we're going to do is try to provide a little bit of a brief overview of each of our topics themselves to help get just the bare bones minimum of what is going on and what we wanted to talk about.
이렇게 소리가
So first, Dr. Hall, what would you say is going to be the summation of what you would suggest?
Okay, because what is the main key for osteointegration? It's not the time, right? So
아니,
even if you're waiting for maybe 3 months or 4 months, it's not gonna get the osteointegration if you do something wrong. Okay? Sometimes you're gonna get bone loss around the implant when even if you submerge it. So the key is osteointegration is not the time, it's the fixation or immobilization of the implant. That's the most important thing we have to think. And the second one is there are two conditions to get for the anytime loading.
Mm-hmm.
The first one is because we have to do the loading. So we need a fixation about 30 to 40 Newton centimeters, not more than that, not less than that. And also, we have to think about the biology. You should not damage the bone. So if you meet soft bone, and you can squeeze the bone, but if you meet hard bone like a D1, you need to be very careful when you drill. So we recommend full side drilling and pre-tapping and get the passive fit on the bone. So that's the two keys.
Good.
All right?
Awesome. Thank you.
Thank you.
For me, what I would say is that we each judge our work based upon our past. If we judge our work based upon our past, is it fair for us to judge our work based upon Dr. Brandemark's work? Or do we judge our work that we do based upon what we are currently doing? On the screen, you see two graphs that are there. If I were to ask each of you, you're getting an implant tomorrow, which graph would you choose? The top one or the bottom one? For me, I gave a Christmas present to my wife in December. I extracted a tooth and did a bone graft. Does anybody want to come to Christmas with me? I am not fun. But next month, I'm going to be placing her implant. Which graph would I choose for my wife? The top one or the bottom one? I chose the same graph for myself that Dr. Hall chose for himself that I choose for my wife. That's because that's the one that I believe in and that I know is right. That graft of being able to take care of the bone and be cautious, gentle with the bone, enables us to have a different primary stability dip. Like I said before, in Colorado, USA, I don't have a stability dip in the implants that I place. I don't have a stability dip in my mouth. Dr. Hall did not have a stability dip in his mouth. My wife will not have a stability dip in her mouth, and I have yet to place her implant. But I know that that's the way that it is true. And so we can choose how we want to place our implants. We can choose the past, or we can choose what you're being presented today and do it that way. It's your choice. But you know where I stand. Dr. Alves, what would you say would be the summation for you?
Thank you. A delicate surgical technique is very important. We have been talking about being delicate with the bone, but for me as a periodontist, we also must be delicate with the soft tissue. But everything starts before the surgery. We need to take a good X-ray, an X-ray with quality, or a CBCT, and we can evaluate the cortical thickness on the X-ray, see the trabecular pattern, and we can have some idea of it is going to expect us. At the beginning of the surgery, with the first drill, with a slow speed, we must feel the bone density. Here, we don't have a recipe, one size fits all. We must individualize our surgical protocol to our patient, to the local conditions. We must perform an traumatic surgery with sharp drills, good irrigation with cooled saline solution, a pumping motion. Don't rush, it's very important. You must be very careful, gentle. When you use surgical guides are an excellent resource, okay? But you have to think about the design of the guide to allow the access for irrigation and give some time between the drilling to allow the bone to cool down, okay? So be gentle and you will have nice results.
Awesome. I love that. Thank you for that. Professor Glackton, what would you say is going to be the summation of your?
First of all, we are here not to show how well experienced we are. We want to share our feelings, what we have when we use this unique product in our everyday practice, and how reliable this CMI concept is, for example, in my practice, as you said, in Colorado, also as in the whole world, because this concept is based not only on the screw type something. This is scientific, this is science, this is more than 20 years of experiences and clinical research, and it's based on everyday development and everyday thinking, how to improve our life quality in our dental clinics and with our patients also as well. So we are super specialists, here, because we are so ambitious. We are doctors and we are among the super specialists, the supermans in the world, as you show in your once in your presentations. But we must not forget that we are doctors, not only specialists, that we have to respect biology, physiology, and this concept is based on this. To respect the physiology, respect the biology, avoid the bone trauma. In hard bone, always use the taper, passive placement, and in active placement, we can use in soft bone with undersized drilling, with self-compaction, and this is unique design implant we can use in every kind of situation what we have dealt in our practice. So I think if we go and step by step and we understand these precise and very important details of this concept, we can achieve that 100% success in our everyday practice. And especially we have to pay attention on recommendations and clinical recommendations, not only from us, but first we have to pay attention and respect the recommendations from company, from manufacturer, what they offers us, how to drill, how to place, how to load, and go step by step. So I think this is most important thing.
Awesome. That's great. Thank you.
Thank you.
Dr. Mongol, what would you say would be a summation of your topic?
Hello, me?
Yes.
Okay. Can the organizer open the light some, because I would like to see the audience. Can they do that? Maybe we knew that in the big event like this, they are like a subgroup also. Some new experience, some high experience, some would like to try the challenge story to build up your ability to treat the patients. I would say in terms of my clinical perspective, firstly, I would like to cheer up the young generation that just only being the newcomers in implant dentistry field. Anytime that you have to use any kind or any brand of implants, Please study in details. Please study in details. Don't believe in salesperson only. Firstly, as I mentioned in my lecture, implant design. You have to understand why this brand design in the apical, in the middle, or in the colonal like this, and how to do the dealing protocol in each kind of situations. Don't be in my pastime, believe in salesperson too much, and working just only one protocol in all of scenario. Second, I would like to share some tip and trick of treatment to the experienced guys. CMI fixation for anytime loading concept. Maybe in the afternoon section, there will be more lecture about this matter. If you do observation about my case, it's a native bone healings. So what does it mean? Sometimes the people, such as mine too, in the past, we concerned that if we would like to do something further after implant placement, we concern just only the primary stability in Newton centimeters, and we can claim that, wow, I can get 35, 40, or 50, 45, 40, 35, something. But the key is we knew that the cortical bone is the area to support the force transmission. So that's why in the beginning that I wrote the brochure of neurobiotech, they mentioned that the success failure will be less than 1%, but we should have sufficient C fixation. So the guy that got the big experience, so in the post-extraction, sometimes that's why we still need temporary restoration with underbiting in maybe many directions. In multiple unit, sometimes maybe we have to evaluate that. How is your final treatment restoration after implant placement? So the dealing protocol, the same that I would like to share. It doesn't mean that we can get the success all the times, but we have to understand well, example, it doesn't mean that I can do the exact prediction that C1, M2, I3, no. Everyone are the same. Tactile sensation depends on our decision. But I recommend that you would like to have like a sparing plan, such as like a example, if you plan and think that it should be like a crucial bone is thick or dense or hard, maybe 2. And middle and eye, maybe 3 or 4. But unfortunately that this is a compromised bone width. When you make it bigger and it touching the labial plate, something like this, it will be more denser. If you use the protocol that just only cortical tapping on the crystal, sometimes it's not enough. Just only the example, but I mean that, don't ask me that, how is my success? It doesn't mean that I can do it just only one shot. Sometimes I have to change my protocol and have the sparing plan in my mind. That's all the message I would like to say.
Thank you, my friend. Dr. Cabrera, talk to us a little bit about, I know you just finished, but tell us a little bit more, Dr. Cabrera, about what you would like to say as just a concise emphasis for today.
Thank you, Dr. Platt. That's a good question. I think it's very important to share with all of you the reason for a consult for a patient, okay? The reason for consultation is very important. We have to establish a good diagnosis, okay? The global diagnosis with the analysis of the soft and the hard tissue condition. After that, we have to evaluate in our CBCT, intraoral scanner, digital photographing, all our kind of things to examine what tools I have to give the opportunity to our patients to establish the immediate implant placement with the anytime loading concept. And in this part, it's very important to remember when we are managing or solving cases with this little device that we call dental implants, in our case CMI fixation, it's very important the implant body designs, okay? The deep thread in our case for the IS2, Dr. Hort mentioned, the IS2 and the IS3 have a different deep, no? And 0.8 and 0.9. After that, it's very important the strong apex. Galak mentioned, is the drilling process is not the same in all our cases. Personal case is we are looking from the primary stability of bicortical or tricortical fixations, we have to be very gentle, like Ricardo mentioned. Also, the Holonext case solution is not the number for me. For me, it's most important the decrease in the number of the surgical times and give the opportunity to achieve anesthetic with function. Also, the main way of the success here, or the success, is an important requirement, and the longevity and the maintenance of our results is the pathway of the 100 lecture. Thank you.
Thank you. Yes.
Okay, I think it's a very surprise to see all the beautiful speakers here. You're giving a beautiful presentation today, but all of them try to say the same idea and the same concept, how to drill and how to get the 100% success, okay? But everybody knows, you know, how to do it, how to place implant. But we have, you know, looks a different way. You know, we are not aggressive, but we are talking about the anytime loading. But we want to get 100% success, right? Mm-hmm. So the message is, right? Please consider bone density when you place implants, when you drill implants. And then we want to get best and ideal fixation in each area. If we meet soft bone, now we know how to handle it, okay? So we can squeeze the soft bone, right? But the hard bone is good for getting fixation. But we have to be very careful, all right?
Yes.
So when you drill, because we know we should not compress the bone and hitting the bone that cause of a bone loss and that cause of severe stability dip. Then when you get 40 Newton centimeters, oh, it's a good fixation. So we want to do loading, but we fail. Because of why? So everybody we knows. So we try to say that this morning, how to get the 100% success even when you do the loading before we get osseointegration. Everybody agree that?
Yes.
Right?
Yes.
Okay,
yes.
Thanks.
So today we've talked about, or this morning, we've talked about a few things. We've talked about the steps and sequence of how we're going to place our implant. My guess is that my wife's bone is going to be a D244. Think through that. How would I go through the steps of placing that osteotomy for my wife? What would I do? How would I check that? I want you to think about that from what you've heard today. Now, as we started this morning, we talked about the Silk Road. This morning, we've laid out our wares to you. We've laid our wisdom to you, and we've shared that with you. You have the opportunity to say, do I purchase? Do I buy? Do I accept what they're telling me? Am I willing to learn more and to do more so that you may join us on the Silk Road? We would hope you would join us. We would welcome you to join us, and we would encourage you to do that. Thank you, my friends, for being here, and thank you, my friends, for your messages today.
Thank you so much. Thank you.